Morning. Hopefully everything is good. Now, I am trying out a new microphone. So if you could let me know if the sound's okay, that'd be great. Morning, Becky. Morning. Well, mind you, I better put a message actually, just in case you can't hear me. It's looking okay from my end. So hopefully everything's good. Morning, Caroline. Good morning. And Neil, Tris, good to see you there as well. Yep, all sound good? Perfect, good. Okay, right, let's get going. So, yeah, we finished off last week. We were just about to go into the ligaments, and we did. We had a look at the ATFL, the anterior talofibular ligament. Thank you, David. Thank you. Thanks, Natalie. Yeah, so we're going to go on with that a little bit more today. And well, hopefully, if we get time, we're going to have a look at the compartments as well of the lower leg. And thank you, Mo. Thank you. And new camera as well. So hopefully that works well as well. So yeah, fingers crossed for everything. I'm doing another course on Saturday, so I thought I'd trial this with you guys that know me, and so if it goes wrong, then you know this doesn't normally happen. Right, let's get going then. So we had a bit of a terminology recap the last time. Just get rid of that, and I think this is quite useful. If you've not really done anatomy before, and if you have, then apologies, but it's always worth going over stuff again. So we did a little bit of this last time, and when we were looking at the different surfaces of the foot, some of the structures are named after those surfaces and the positions of things. Okay, so when we were looking at the toes in particular, so the phalange bones, we had distal and proximal phalanges, or proximal distal phalanx. So again, it's useful to go over those again. So we've got the dorsal surface, which is the top part of the foot, and then the plantar surface, which is the underneath bit, and then proximally is towards the body, distally is away. So we can work out where things are, and this is the anatomical position that's on this skeleton. So standing facing forward with your palms facing forward is where we kind of orientate ourselves, where everything comes from. So everything is distal, proximal compared to the anatomical position. Okay, so we've got this standardized position that makes it easier for us to locate things, basically. Then we creeped into this last time, so we're looking at the lateral ligaments on the outside of the ankle, and there are a few there which we're going to have a look at. These are the most commonly injured ligaments, excuse me, and there are some tests that you can do for them, and when you see where the fibres go, and then the restrictions that they're going to have on movement, it then makes it obvious why we do the test the way we do. And you can also use landmarks to help you palpate those regions whilst you're doing the tests as well. So if someone's got a sore ankle, I mean, if it's just happened, it's going to be swollen, so you can't really feel anything, and nothing really moves either. It's only really when the swelling goes down that when you do the testing, it can be positive. So sometimes it's obviously positive even with swelling, but if you're kind of umming and ahhing, it might be because of the swelling. So sometimes we have to wait for that to go down before you can get make any sense of some of the clinical tests that we do. But obviously in their story of how it happened and the kind of feeling that they had and the noises that it made, you may think, well, this person's fractured it anyway, so we need to send them off for imaging. But it's a similar kind of situation with the knee. I've mentioned this on the courses that I teach when doing a knee examination. You see the tests for testing the ligaments, and the amount of laxity, it's like, whoa, that's really obvious. But when people first do it, the knee is just like a balloon. It's really, really swollen. So when you do the tests, nothing moves at all. And also it's not a great time to do imaging for soft tissue at that point because of all the congestion as well. So sometimes we have to wait for a couple of weeks for things to calm down, and then we can get imaging done and do the test. So yeah, it depends on the scenario and the timings of things. So lateral ligaments then. So we've got these three main ones. Excuse me. ATFL is your anterior, so it's at the front. Talofibular ligament, so it goes from the talus bone, which is here. And again, we've been covering the bony anatomy over the last couple of weeks. So if you've never heard of the talus before, go have a look at the bone videos at Bones and Joints, and we did a whole session where we covered the talus. So we've got this bone here, and then this is your fibula, and then the end of the fibula there, that's called the lateral malleolus. So it's on the lateral side, which is the outside, and we've got this basically a bony lump. Again, last week we were kind of using that as a landmark to find other bony landmarks. This time we can use it as a landmark to palpate ligamentous structures. So if we have a look at the ATFL, it comes off the front of that fibula, attaching onto the talus just there. So the only way that you're going to stretch that ligament is by, if you plantarflex the foot, so if you bring the foot down so the toes are pointing down, and then roll the ankle inwards. Okay, so hopefully that kind of makes sense. So look at the direction of the fibres, yeah? So if you point the foot down, then that's going to stretch it. Okay, so we'll elongate those fibres as it goes into plantarflexion. But then if that's combined with a rolling in of the calcaneus bone, so this one just here, and again, we talked about this the other day with the calcaneus going in is called inversion. Okay, so we're looking at the back of someone. If their calcaneus is going in, that's inversion. So if you've got plantarflexion and inversion at the same time, that's going to really stress that ligament. Okay, so that's a really common mechanism of injuring that particular ligament just there. And then the test that we do to test this ligament is well, you can do what's called a talar tilt test. So you basically put the ankle into that position to stress the ligament, and what you do is you find the lateral malleolus and then you palpate just in front. And when the ligament's intact, because the foot's quite there's not very much tissue on the dorsum of the foot, as you bring the foot into plantarflexion and then inversion, you can often palpate the tightening of that ligament as it goes into that position, and the ligament kind of pops up into your thumb. Yeah, so if you put your thumb in that kind of space there, as you do that movement, you can feel it tighten up. Obviously, if it's injured, then it will keep going because there's nothing to stop it. The other test that we do is called a draw test. So you hold behind the calcaneus here, and then you pull in that direction. So you're pulling the calcaneus forward as if you're trying to slide the whole foot away from the tibia and the fibula. So obviously, if that ligament is not there, then the foot can move, yeah, because there's no ligament stopping it from moving forward. So again, hopefully knowing the anatomy and knowing the test, we can see why those tests are done, but then also there's the caveats about the specificity of those tests and the sensitivity. So we do have to take the clinical testing side sometimes with a pinch of salt, but you've got to mix it into the whole story. So if the story fits, the clinical test fits, it's often a good idea to get some imaging of these ligaments if you think that they've been injured. Okay. Then we've got this one down here. This is the calcaneofibular ligament just there. So this is the CFL, and the calcaneo is to do with the calcaneus, so that's your heel bone, and then fibula, obviously the fibular bone again. Okay, so the names of the bones give rise to the names of the ligaments to make it a bit easier. So we've got calcaneus attachment here, and it's slightly oblique usually, okay, and attaches onto the fibula, the lateral malleolus just there. So again, going into that inverted position, we can stress this ligament just here as well. Okay, so that the talar tilt test, so where you bring the foot into inversion, that's quite a good one to stress this one too. And again, you can palpate that. Okay, feel that to see if the ligament is tightening up. And then on the back here, we've got the posterior talofibular ligament. Now, this one's a bit more difficult to palpate because it's quite deep, and you've got the well, running from here up into the calf, you've got the Achilles. This area is filled with a fat pad as well, so we'll have a look at some of the images of that. You don't see them on cadavers because the fat disappears. Okay, so unless it's, sorry for the kind of graphic nature of it, but unless it's fresh, okay. But if you having a look at some formaldehyde set cadavers, then you don't see the fat pad. Okay, so it's just gone. So there'll be a gap here on a cadaver unless it's not been dissected out. So yeah, you've got the Achilles there, so it's quite a deep structure with lots of stuff around it, so it's not as easy to palpate there as that one and that one. Okay, and then again with this one, if you have a look at the direction of the fibres, it would make sense that if you try to push the foot the other way, okay, so place your hand over here and do a posterior draw, so you're trying to move that foot from front to back, the posterior talofibular ligament, so this one at the back here, would stop that movement. It would block it, because as you push it back, the ligament would stretch, and if it was intact, then it would stop that movement. Okay, but if it's not, then it would continue to glide potentially. So we've got posterior at the back, talofibular, so talus to fibula. And that one could be a bit confusing because you think, well, hold on, the talus is at the front, but the talus bone goes all the way underneath. Okay, and again, have a look back at the bone video to make sense of that one. So let's have a look at those. Here we go. Sorry, got microphone, new mic just there, and I've got a coughing fit today, sorry. Okay, so there's your talus bone, and there are your medial ligaments. Don't worry about those just for now, we're focusing on these ones. So there's your ATFL just there, attaching onto that talus. So there, that is a great image. I think we saw this last week. So if I just pause that there, that join there, that's your talocrural joint. So the joint between the talus and the tibia and the fibula. So tibia and fibula go like that, and then the talus slots in, and the movement that occurs there is plantar flexion, dorsiflexion. We talked about that last week. So this ligament here, you can see when you go into plantar flexion, it stretches it. Yeah. So let's have a look at that. So there it is there, and as the talus nods forward, so if you imagine the whole foot obviously attached to that bone, that would mean that you'd be pointing your toes downwards, okay? And that's what stretches that particular ligament. So it limits the movement of the talus into plantar flexion. But if you're combining that with an inversion as well, and as we talked about last session, ligaments don't like a shearing motion, okay, that kind of twist. They're very good in a straight line, but they're not good with a twist. So if you've got down and twisted, that's a perfect recipe to injure this particular ligament. And that's quite often what you'll hear people say is they stepped on a curb and their kind of front of their foot went down and then their ankle rolled. Or if they're playing sports, they might step on someone's foot, and as they're standing on the foot, they go into plantar flexion, and then because it's unstable, they roll and invert the calcaneus, and they're quite common ways for you to injure that particular ligament. And then if we come around the back, there's the PTFL just there. Okay, so you can see how deep that structure is. Yeah, round the front, there's very little tissue. So if we have a look, yeah, it's that one just there. There's very little tissue there. There's nothing on top of it apart from skin. But this one round the back, like I said, the Achilles is here. This whole area is full of fat pad. So this area around the back is full of stuff. Okay, so to be able to palpate that is pretty much impossible. And then there you can see the movements again. And there's the tautness of it there. So that's when the foot is in dorsiflexion, the ligaments become really tight at the back. We'll talk about the deltoid ligament in a sec. We've got another video that goes into that in a bit more detail. But yeah, the inside ankle bone, so the medial part of the ankle, there's a whole bunch of ligaments just there. Here we go. So yeah, these are the movements prevented by the ATFL, PTFL, and the deltoid ligaments. So the sliding forward and back of the talus and the tilting of the talus as well. If I just take that back there. That's a really good question. How can inversion tension the ATFL if the talus only does plantar flexion, dorsiflexion? It only does that when it breaks. Okay, so as it goes down and then you just can't control the inversion, you'll reach the end of inversion for the subtalar joint, and then because of the mechanism, because of that movement and then the twist on the ligament, that then stresses the ligament so much that the ligament breaks. Okay, so it's not from the talus movement, because the talus isn't supposed to do that. It's the wind up of the subtalar joint that reaches the end of range. The only thing that's left to stop that is your ligamentous structures, and if it's enough force, they'll just break, and then that's when you get the ligament injury. So that's a really good question. Morning, can we have a minute to talk about Haglund's syndrome, please, and what are the options? Cool. I'll do that when we get to the Achilles, if that's okay. Yeah, so we'll I'll mix that into the Achilles session. Good. Yeah, so there, I think we covered that. Yeah, just want to have a look at these movements. So these are the movements that we prevent. So that, I mean, obviously that movement there, if I just go back, what Tristan just picked up on, so that kind of tilting side to side, that is not a physiological movement. That should not happen at the joint. That's what the ligaments are there to prevent. But if you get such a wind up of the joints underneath, then it will break the ligament. Okay, cool. So yeah, we've got that tilting that they avoid, and then the gliding backwards and forwards as well. So those are both non-physiological movements. Your ankle should not do those movements because the ligaments stop them. But when you injure the ligaments, that's when those types of movements occur. So that's why we do those tests, because your ankle shouldn't do the movements that we're trying to get them to do on those tests. Yeah, so we're looking for that abnormal movements. Cool. Okay, where are we at? Perfect. Medial ligaments. Now, this is an interesting one. We've just seen a little snippet of the deltoid ligaments on the inside of the ankle, and you can see that it's not very clear like it is in this picture. So we've got 4 ligaments all together. Yeah, so anterior tibiotalar this time. Yeah, so going from the tibia to the talus. Tibio-navicular ligament, so tibia to the navicular bone. Tibiocalcaneal, so tibia to calcaneus, and then posterior tibio-talar, tibia to talus again, round the back this time though. So 4 ligaments in this picture, which all look nice and neat. Yeah. Now, what these ligaments do, and if we think about the mechanism of injury of the other ones, so we've got a plantar flex position and inversion, injure the lateral ligaments. What will injure these ones is a plantar flexion and eversion. The only thing is though, that movement is blocked by the lateral malleolus. So the outside ankle bone drops down lower than the inside ankle bone. So you have a bony blockage stopping eversion or excessive eversion of the subtalar joint and then therefore the talus. So injuring these ligaments is much less likely. What usually happens if you have an eversion sprain, so where the calcaneus goes outwards, is you fracture your lateral malleolus, yeah, and then you will injure probably injure the ligaments as well, yeah. But to injure these is quite unusual. Usually it's the other way around, and that's just because of the anatomy. So where the fibula comes down, it blocks eversion, but inversion is really easy because the tibia is a bit higher. So it's not like that, like a perfect U shape around like that. It's slightly less on one side, slightly more on the other. So if I try and go that way, it's going to be blocked. If I try and go that way, it's going to easily go because there's no bone blocking it. Okay, so that's why in your knowledge bank you definitely need good knowledge of the lateral ligaments, because they're the ones you're more likely to see. Those are the ones that are going to get injured more frequently. Okay, let's have a look at the deltoids. Hopefully, here we go. So we've got the CFL on this one as well, calcaneofibular ligament, and the deltoid ligaments. And again, remember there were 4 of them, but when we look at the images, good luck if you can make out 4. Okay, so here's the deltoid ligaments all around here. Yeah, they look like just a complete mesh of tissue, so that it's not very distinct, basically. Okay. There's your calcaneus, there's your talus. So that would be your tibio-talar. Kind of make out the tibio-calcaneal. That would be tibio, maybe talus, but these are all the attachment points here. Let me just pause that there. So these are some really good bony landmarks to understand, to palpate. So we were going through these last time, and some of them are easier than others. Some of them are quite, I've got a fair bit of tissue on top of them. But medial malleolus is where all of these ligaments attach. Then we've got the posterior aspect of the talus. That's going to be as difficult as the other side to feel, because it's quite deep and there's some other tissue there. Sustentaculum tali, that we did in the first session to do with the bones. So that one will be a good one to learn how to palpate. That is often quite sore, but there are some other structures that are around there as well. So the specificity of the palpation isn't very good. It wouldn't indicate what exact structures are injured, but it depends on how it ties in with the mechanism of the injury, and so it may raise your suspicion of a ligamentous problem if they had like an eversion event. Okay, but there's some other stuff that attaches onto there, which we'll talk about in a bit. And then medial malleolus just here again, and then down onto the talus. So you can definitely palpate that region, but again, there's some other structures around there too. And then the navicular, there's the tuberosity of the navicular, and it's just superior to that. Okay, so if you can find navicular tuberosity and slide up, and all around that area is tender, then maybe there's some ligamentous injury. Okay, but again, we use those bony landmarks and the movement. So if you try to evert the ankle to stress those ligaments and feel at the same time, just to test their integrity. Again, you're not going to be able to feel individual ones like you can feel on the lateral side, but as a group they should all tighten up as you move into eversion. Okay? And again, if they don't, then there may be some injury to the ligaments, but again, usually that coincides with a lateral malleolus fracture if they've gone over on it. Okay, so that's all the bony landmarks to check out for. But you can see the images from before. Let me just pause that. That it's really difficult to distinguish between them all because they all kind of merge in together. Now here's your lateral malleolus. So we've gone back to the outside. Your ATFL will run off that way towards the talus, and then we've got this ligament here. Can you see that there? So it's kind of running obliquely backwards to attach onto the calcaneus just there. So if this calcaneus goes in into inversion, it will stress this ligament, okay? Because that's your heel bone just there. Just play this through. So there's your CFL. That was quick. Let's go back to the deltoids. I just want to show you that again. There we go. There we go. Look at that. Yeah. So a complete kind of mesh of tissue. Just go back there again. I mean, that one you can just make out is separate, but all of these are pretty much all joined together. And it's deltoid because of the shape, like a triangle shape. So it's wide at the base and pointy at the top. Which is the delta sign in Greek. So that's why the deltoid in the shoulder is called the deltoid, because it looks like a triangle, which is delta in Greek. So there's your CFL just there. Okay, cool. So that's your lateral ligaments, ATFL, anterior talofibular ligament, PTFL, posterior talofibular ligament, CFL, calcaneofibular ligament. Those three are the ones, well, mainly CFL and ATFL are the ones that usually get injured with ankle sprains. Right, so those two definitely are well worth looking into. The deltoid ligaments, those four, are kind of as a group, yeah, all the way around the medial aspect of the ankle, and again, less likely to get injured. So if you are prioritizing things to study, then I would go for lateral ligaments first and then these ones afterwards if you needed to prioritize it. Cool, okay. Excuse me. Now we're going to have a look at the dorsal ligaments. And again, if you look at this picture, these all look as if they're, you know, individual ligaments and you can see them really clearly. And look at all the different names, okay? That dorsal metatarsal ligaments, bifurcate ligament. There is no way that you're going to be able to palpate these individually and identify a specific ligament that is injured. Yeah, no chance at all. It's quite unusual to injure this mid part of the foot. But it can be done, definitely, and it can be done with a inversion or eversion sprain. But obviously the pain is in a different location, symptoms are in a different location, and know someone recently who's had an injury to this mid part of the foot, and it blows up like a balloon. Hey, you can have what's called a Lisfranc injury. So the Lisfranc region is this midfoot region around here, and you can have fractures in these bones in the midfoot. Yeah, so obviously you need imaging to have a look at this. Now, with the person that I know, they went to A&E straight away as soon as they had the injury because their foot was swollen like a balloon, and then they imaged the ankle, but I think they imaged this part of the ankle because they thought that it might be an injury to the talocrural and hindfoot, and they didn't see the Lisfranc fracture on the very first imaging that they did, and obviously it wasn't getting any better because there was no fracture there, they just thought, oh, it must be soft tissue injury. So do your rice initially, and then peace and love, and do your early kind of graded movement. But it wasn't getting any better, and so they went back again a couple of weeks later, and they imaged it again, and this time they found the Liz Frank fracture in the midfoot. Okay, so don't be afraid to ask for imaging again if things aren't going the way that you think that they should be. Okay, so that's an area to have a look at. So we've got ligamentous injuries in this dorsal region, but also can be fractured as well. Okay, so you get like an avulsion fracture in that midfoot. So just again something to look out for in that region. Let's have a look at this. Here's the dorsal ligaments. Here we go. So again, we've got a whole kind of slab of ligamentous tissue, all of that connective tissue. So that's your dorsal ligaments just there. So they're obviously going to provide the integrity for that mid part of the foot, making sure that all of those bones are stabilized. But you can see like the picture here where it's got individual ligaments, there is no way that you'll be able to identify those. I mean, that's been dissected out really well, and you still wouldn't be able to, you'd struggle to do it even without the skin on. Okay, so with the skin on, yeah, you're going to struggle. But that's the region. If you have gone over on the ankle again, and it could be inversion or eversion, but the forces could have gone through the midfoot rather than the hindfoot, and then you've injured the midfoot rows rather than the lateral or medial ligaments. Okay, so again, just something to add to your clinical reasoning. Now, this ligament is one that attaches to an area where we've already had a look at the bony landmarks. So like I was saying, that sometimes if you try to palpate something and you go, oh yeah, that must be that ligament, but there's another one that attaches to it as well. So you can't be that specific with the identifying a bony area. If it's tender, it's that's the problem. It doesn't work like that. Okay, so again, we have to refer them on for further testing, because we wouldn't be able to be specific without that imaging. So this ligament, I'll move that around there, it supports the head of the talus. Okay, so that's it there, just there. Now we've talked about these a little bit before. That shelf there is your sustentaculum tali. So that's part of the calcaneus that comes out, and then the talus sits on the top, and you can palpate that quite comfortably. Okay, and if you remember from a couple of slides ago, the deltoid ligament, or one of the deltoid ligaments, attaches on exactly the same spot. Okay, so if you and there it is there. So you got your tibio calcaneo ligament, or part of the deltoid ligaments, attaching onto there, and then we've got the spring ligament coming off of exactly the same bony landmark. So that can be a really sore area. Now this ligament often gets confused, along with a couple of others, with plantar fasciitis, because of the location of the ligament. It's fairly close to the calcaneus, and it's on the undersurface of the foot, on the medial aspect, so on the inside of the foot. And if you're kind of poking and prodding around the inside of their foot and it's sore, you might think, oh, it's plantar fascia, yeah, but it could be this spring ligament that's irritated. Would it change your rehab of it? Probably not. Okay, but if this ligament is significantly injured, then it will affect the movements of the talus, okay, and the stability of the talus. So we do have to be a bit careful with this one. So it supports your medial arch, okay, and the video will be great. It'll show exactly what I mean in a sec. It has some part in the talocalcaneonavicular joint, and we've seen that before. A couple of weeks ago we had a look at that. It's called the spring ligament because it helps the arch spring back. So when you step on the heel and then you go into start to pronate the foot, which is a combination of different types of movements, as that middle part of the foot starts to flatten, this spring ligament stretches, okay, to allow the talus to drop down, and then along with everything else, all the other connective tissue in the body and the big toe, you then get your arch coming back, and then the spring ligament shortens as well to recreate the arch in your foot so you can toe off. Yeah, so that ligament there is really important for gait. Yeah, so but again, it's difficult to be specific without further testing. So the sustentaculum tali is where it attaches, so that bone just there, or that bony landmark, and then onto the navicular tuberosity just there. So again, we've got another ligamentous structure that attaches onto the navicular, as well as this part of the deltoid ligament as well. So you can see why it gets a bit messy with being specific with things. Let's have a look at the spring ligament. This is it. Okay, so let me just pause that there. Right, so there's a big bone missing here. See if you can spot it. So there's your calcaneus just there. So you can see the kind of shape of the calcaneus as it's coming down. There will be your navicular, I think is that one just there. And around that area there will be your sustentaculum tali. All right, so what they're going to do in a sec, they'll add the talus in, I hope. But you can see from the top down with the talus removed, that's what the talus sits on. Okay, so there's your calcaneus, yeah, there's your navicular just there. Sustentaculum tali. So those are all those structures that we've just seen on the picture. And then this is the spring ligament just here. So you can see there's a bit of a gap between sustentaculum tali and the navicular, and that ligament bridges the gap. So it's like a hammock for the talus bone. Oh, I didn't put the talus in, that's a shame. Okay, so the talus is on the top there. So when you go into pronation and your foot flattens, that spring ligament will stretch along with other structures, we'll talk about those as well, and then the talus will drop down into the hammock of the spring ligament, and then when you toe off, the spring ligament will spring back again and help you to recreate the arch in your foot. So that is a common ligament to irritate if you haven't done any exercise for a while, and then all of a sudden you take up park run and you think, oh, it's only 5k, but 5k is quite long when you haven't done anything for ages, and you start to feel achiness on the inside of the foot. And if you don't have it assessed properly, you just Google it and you think it's plantar fascia, but it can be the spring ligament that's affected as well. So if you were going to do specific treatment on it, so things like an injection or focus shockwave, something like that, then if you shot the focus shockwave into their plantar fascia, it wouldn't affect that at all. Or if you put the injection in there, then obviously it wouldn't affect the structure that's the problem. So you need to be able to palpate around these areas, as well as the story, as well as the imaging, to get the right spot. Okay, so that spring ligament's a key one for that kind of overuse type injuries usually. Right, let's have a look at this. Yeah, so syndesmosis. What time is it? Yeah, cool. Okay, we're definitely not going to get to the compartments. So syndesmosis, we've talked about this a little bit before as well, and it's another ligament in the high part of the ankle, so above the talocrural joint, that joins the tibia and the fibula together. Okay, and we've talked about this when we had a look at the bones. So let's have a look at a picture first. Just bring that up there. So there's your tibia, there's your fibula, and in fact this is a good image. So can you see how the lateral malleolus is a lot lower than the medial malleolus? So that's what I was talking about before, where that's why the calcaneus will invert really easily, because there's nothing, there's nothing stopping it on this side, okay, but it won't evert because of the blockage of that fibula. All right, so that's why you usually get inversion sprains rather than eversion sprains, because of the location of that lateral malleolus just there. But yeah, just inside of the lateral malleolus and in between the joint here, we've got this ligament here. So from the tibia to the fibula, which is your syndesmosis. It's the crural interosseous membrane. So this here, interosseous membrane just there, lies between the superior and inferior tibiofibular joints, right? And oblique fibres unite the fibula and the tibia. So you can see the direction of the fibres just there. Yeah, it increases the surface area for muscle attachment around this point. There is another ligament at the back as well, so there's a posterior syndesmosis as well. But the way that this gets injured is if your foot is, you're wearing either very sticky shoes, like court shoes, like if you play basketball or netball and you need to pivot and turn. If your foot gets stuck, or you're wearing studs like in football, foot gets stuck in the ground, yeah, and that doesn't move, but then you decide to change direction, so your tibia and fibula twist, and that twisting action with the foot stayed still opens up this joint. Yeah, and that's, or you get tackled and your foot goes in a certain position, but it's basically corkscrewing the talocrural joint, which obviously again, that movement shouldn't happen, but with enough force it can, and you will or you can injure these ligaments just up here. So let's have a look at those. I think it is this one. Just get rid of that. Yeah. So we've got interosseous membrane, so in between the two bones, and then the syndesmosis ligaments on this video. So there's your fibula, there's your tibia, so lateral malleolus, medial, tib and fib. And then in between these two bones will be this membrane that separates the front and the back of the leg. There it is. So that's your interosseous, so in between the bones, membrane. Really, really tough stuff that is. The bones will break before this does. It's really, really tough. There's your proximal tibiofibular joint, which we'll talk about when we get to the knee, and there's the distal. So remember that the proximal towards the body, distal away. So this is the distal joint, and then there's the ligament just there. Okay, so if your talus was in here and your foot is locked, and then you rotate to turn in a different direction, or you get forced in a different direction by a tackle or something like that, then you can injure that ligament at the front. And that's it there. So it's up in an oblique upward direction, and then we've got one at the back as well, just there. There you go. The syndesmosis can break, yeah, it's basically surgery to pin the two bones together, because otherwise they'll be unstable. So the test that you do, there's quite a few tests. There's a squeeze test, there's a glide test. So you grab hold of the fibula and you give the fibula a wiggle and see if it moves. Obviously it shouldn't move, but because the ligament should be intact. But if it does move, then we're suspecting a high ankle sprain, okay, or detachment. Yes. It is a very obvious, almost stomach churning experience when you get a positive test. It sounds like from experience, that one. Yeah. Yeah. The thing is, with all of these, it's like, is it injured? And if you're asking the question, is it injured? It's probably not. Or there's too much swelling to test it. Because when they're injured, it's so blooming obvious. Because they just wiggle about like they shouldn't do, and it's all unstable. And yeah, an ankle should be solid. Nothing should really move very much. But yeah, when you get one that's not great, then yeah, you can see it. So the best thing to do, I think, with all of these things that we've looked at today, is have a look on YouTube for positive tests of syndesmosis, ATFL, CFL, and have a look at the tests that are positive, and you can just see, because the joint laxity is insane, and yeah, it just doesn't look normal at all. So yeah, that's the best way to learn it, I think. Have a look on YouTube. Someone somewhere will have videoed someone with a dodgy ligament. Okay, cool. So microphone worked well, camera worked well. That was all good. Thank goodness for that. We are done for today. We've got a couple more ligaments to have a look at, actually. So we'll continue that next week. And we will definitely have time then to have a look at the compartments of the lower leg. So, and that's a really good session, because those compartments show you where the muscles go. So it leads into the next session. Okay, cool. I'll see you next week.